So our patient is a 20-year-old male who plays football and comes to outpatient rehab for fracturing his dislocating his left ankle while playing football. The injury happened 1 month ago, and he presents to physical therapy 3 days after his cast removal. The patient had an ORIF surgery that was done 4 weeks ago to his left ankle. He comes to physical therapy on crutches, accompanied by his father for support. He is allowed to weight bear as tolerated. The patient displays limited palm range of motion with, for all ankle motions, decreased balance, decreased flexibility, and weak plantar flexor muscles. He also has pain with weight bearing on his left ankle, ascending stairs, and ranks that pain 8 out of 10. The patient is very motivated and enthusiastic about returning to football. So for our activity and limitations, the patient is unable to walk independently, is unable to ascend and descend stairs independently, and has difficulty with sit to stand when he is not using any assisted devices. For participation limitations, he is unable to play his favorite sport, which is football. He has difficulty getting to class due to the use of having crutches. It takes him a longer time. And he has also difficulty socializing with friends and teammates because, he can't access and go certain places due to his condition, and he can't interact with teammates due to his condition as well. He can't attend practices. For environmental factors, the student lives in a dorm with a roommate on the second floor. Limited help in his living environment. He has some help with his teammates, but is not consistent. Patient is able to attend class, but needs more time, as I mentioned before. And patient expresses that he really wants to walk without crutches as soon as possible. The personal factors: he is single, he's 20 years old, and plays football at his current university. The patient has never fractured his ankle before, but he has a strong desire to get better. He still attends practice, but watches from the sidelines as a way to cope with his condition. Patient is young and expressed wanting to start back running again. Like I said before, when introducing the case in the beginning, he does his little morning jogs on Saturday mornings.
After 4 weeks of immobilization, the patient presented to the clinic with decreased active range of motion in the left ankle, with 2 degrees of dorsiflexion and 15 degrees of plantar flexion. He was also limited in the directions of inversion and eversion. Accessory passive range of motion found a hypomobile talocrural joint in both the anterior and posterior directions. The patient presented with decreased balance with a Berg score of 15 out of 56, considering him a high fall risk due to his pain with weight bearing. Manual muscle testing was completed and determined the patient had only 3 out of 5 strength in the left ankle for both plantar flexion and dorsiflexion. His right ankle was normal for strength and range of motion.
The following are our SMART goals. In 6 weeks, the patient will be able to hold a single leg stance dynamic balance on the left lower extremity independently on a 4-way balance board for 30 seconds in order to improve single leg stability and proprioception in preparation to return to football. In 4 weeks, the patient will be able to fully weight bear on the left lower extremity with 0 to 2 out of 10 pain in order to be able to climb stairs and ambulate independently. In 6 weeks, the patient will improve ankle MMT and all motions to 5 out of 5 strength in order to return to playing football and ambulate with normal gait. In 6 weeks, the patient will test greater than 9 centimeters from the wall in the dorsiflexion lunge test in order to return to sport, climb stairs, and jogging. The purpose of these goals was to ensure the patient has appropriate stability, flexibility, strength, proprioception, and motor control, not just in the ankle, but along the entire chain of the lower extremity. This will ensure his sport performance and ADLs are not only restored, but also optimized in a way that will prevent him from re-injury. Next, we will go over the dorsiflexion lunge test and the movement analysis and interventions that will address these goals and the patient's desire of returning to football.
The dorsiflexion lunge test is a test that evaluates ankle range of motion into dorsiflexion, which is essential for walking, climbing stairs, and jumping. To begin, you'll need a wall and either a measuring tape or a ruler. So I'll begin by placing my hand in front of my foot against the wall. I'm going to align my big toe to my thumb, and I'm going to place the ruler just off to the side so I can see pretty much just a baseline measure of where I'm currently at in this position. I want to keep my kneecap in line with my second toe, and I want to drive my knee forward to see if I can touch my knee to the wall. If I can't, then I would just move my foot closer to the wall and keep a record of that measurement from my big toe to the wall. Anything less than 9 to 10 centimeters indicates ankle restrictions into dorsiflexion. And for our patient, we would anticipate that he would have limited range of motion at the ankle going into dorsiflexion.
The D1 lower extremity extension pattern is most appropriate for our patient as it will incorporate plantar flexion and eversion. The patient will start in flexion, adduction, and external rotation and move into hip extension, abduction, internal rotation, knee extension, ankle plantar flexion, and ankle eversion, and toe flexion. The techniques that we will perform with this exercise is combination of isotonics and repeated stretch. Combination of isotonics will combine concentric, eccentric, and isometric contractions of a muscle group without relaxation. Goals for this technique are to improve active motor control and motor learning, improve coordination, improve active range of motion, improve strength, and eccentric control, and improve function. Repeated stretch is a stretch reflex elicited from agonist muscles under tension from contraction. This can be performed at the beginning of range of motion or throughout the range at points of weakness. Goals for this technique are to enhance initiation of motion and motor learning, increase strength, improve intramuscular coordination and intermuscular coordination, improve range of motion, reduce fatigue, and guide desired motions. Some common compensations for this technique will be trunk flexion or anterior pelvic tilt and pelvic posterior depression. If our patient is unable to perform combination of isotonics and repeated stretch techniques, a regression would be rhythmic initiation to promote the learning of the movement.
For our next intervention, we chose to do the 4-way balance board using the Bosu ball. This is going to challenge the patient's balance, stability, and core strength. We felt this was appropriate because it's going to challenge him in the ways necessary for his sport. With football being a contact sport, your body has to be able to adapt on the go. So this will help promote firing of those muscles and as well extra muscles to help take load off that ankle. So with that, we have the therapist standing at the side of the patient. This is just for support, or if the patient fatigues, we're going to be there to be able to assist. So what they're going to do is go into 6 different directions. We're going to go forward and backwards, shift side to side, and then we'll go clockwise and counterclockwise.
Each direction will be performed for 1 minute, and so we'll also combine directions. So we'll go forward and backwards for 1 whole minute, side to side for 1 whole minute, and then as well the clockwise and counterclockwise. So while the patient is doing this, we want to make sure they're not excessively using their trunk for balance. We want to promote using everything from the ankle, the knee, the hip, and the core. So the idea is to have a wide base of support, make sure they're activating that core, and then just giving them cues. If we see them struggling a little bit, make sure they get back to neutral before continuing the exercise. And then just overall, just promote safety. This is a ball, so there is always that chance of it popping, or just in case something like that happens, we'll be there. So with this, if the patient is doing pretty well, we can incorporate the single leg balance, and we'll do that for both legs just to make sure we are getting both legs incorporated. And also you can do a ball toss. This will further challenge the patient to fire those muscles and be ready to adapt on the go. And then if the patient is struggling, we can always just take out the Bosu ball in general and go back to a flat surface and work on weight shifts until the patient gains more confidence and strength in that leg.
Isotonic calf raises are beneficial for the patient because this exercise strengthens the muscles and ligaments of the ankle. This exercise will help the patient take his ankle through full plantar flexion range of motion, which is necessary for stair climbing. To perform this exercise, the patient will be standing in front of a chair with both feet on the floor. Verbal cueing is given to raise both heels off the ground as high as possible while using the chair in front for support. The patient will begin the exercise with a concentric contraction. Hold an isometric contraction for 3 seconds at full plantar flexion, and then return to the starting position with an eccentric contraction in a controlled manner. The patient will perform 10 reps in 3 sets. Compensations for this exercise may include excessive knee flexion or leaning forward due to weakness. A cue to avoid excessive leaning forward can be to ask the patient to imagine that she has a string in her head and that is being pulled towards the ceiling. If an eccentric contraction is too much for the patient, the regression will be to perform seated calf raises. If this exercise is too easy for the patient, a progression will be to perform single leg half raises. Our goal for this intervention is that in 8 weeks, the patient will be able to fully weight bear on the left lower extremity with decreased pain in order to climb the stairs to his room. The 4-way ankle TheraBand exercise strengthens the ankle in 4 different directions, which are dorsiflexion, plantar flexion, eversion, and inversion. Since our patient's ankle is weak and restricted, this exercise will help regain muscle strength and mobility so the patient can ambulate and climb stairs. To perform this exercise, the patient will be sitting on a mat or a table with the involved leg extended and the ankle off the table. Then, a TheraBand will be used to add resistance in the directions of plantar flexion, dorsiflexion, inversion, and eversion. For plantar flexion, the TheraBand will be placed on the plantar aspect of the foot. For dorsiflexion, on the dorsum of the foot. For eversion, on the lateral aspect of the foot. And finally, for inversion, on the medial aspect of the foot. The patient will keep the leg extended and will perform first an isometric contraction for 3 seconds, followed by a controlled eccentric contraction, and will end with a concentric contraction. The patient will perform 3 sets of 10 reps for the 4 motions. Compensations for this exercise may include the patient bending the knee due to weakness, or patient may also demonstrate poor control of an eccentric contraction. If the patient is unable to perform this exercise, a regression will be an isometric contraction in all of the directions. If this exercise is too easy for the patient, a progression will be to add a black resistance band. Our goal for this intervention is that in 8 weeks, the patient will have 5 out of 5 strength in the 4 motions at the ankle, to improve overall ankle integrity in order to get back to jogging in the mornings and playing football.